Thanks very much, Wes, for that flattering introduction. Most of you probably didn't come to find out about sustainability of the Canadian healthcare system, and perhaps you're curious why this talk was chosen. It follows, I think, from the fact that at the Population Health Research Institute, I was asked to give this presentation by Salim Youssef, and Wes was there, and people found it quite interesting. And I suspect that's what inspired Wes to ask me to do this. Nevertheless, you might say, but that's not why I came here. If so, blame Wes. So what I'm going to do, if my slides change as they should, there we are, I'm going to define the issue for you. I'm going to talk about the current funding structure, a little bit about, most of you I understand, I think over 95% are from Ontario, so it'll be a very brief reminder. For the 5% who are from elsewhere and outside of Canada, it'll give you a little bit of background about the Canadian healthcare system that I'm talking about today. I'm going to ask you to think about how we should decide whether the Canadian healthcare system is sustainable. And one of the successes at the PHRI talk was that it was very interactive. It's very difficult to do an interactive talk with this size room and audience. I've been, however, in front of audiences before of this side where courageous individuals were ready to shout out. So I'm going to ask questions and see if anyone's courageous enough to provide some thoughts as I go along to get us involved together. And I'm going to move then to issues of funding, private versus public, and again the question will be how to decide on the merits of private and public funding for healthcare and what evidence is available to inform that. So, sustainability. We have, with respect to physician and hospital services, universal publicly funded health care very largely, not completely, but very largely. And the issue that has had a lot of public debate and attention is to what extent is it sustainable? And behind that question is how we should spend our national wealth. And we're often very focused on what to do within the healthcare system. But there are broader issues behind how we spend our wealth that actually bears on this. So the first basic decision is how much of the Canadian wealth should stay in our pockets as private income, and how much should support public endeavors through taxes. Once we've decided how much is public funding, then where does that get spent? And it can be spent on social and health services, which the people in this room are very interested in, versus, for instance, infrastructure or military spending. And then, once we decide how much should be spent on social services, how much do we advocate, how much do we leave or allocate to health versus education? And then finally, within the healthcare system, how do we struggle to divide the funding that we've allocated there? So it's a very broad set of decisions that I think we often forget about when we're focusing just on healthcare. And then within healthcare, the issue of public versus private payment. This slide tells us why there are a lot of tension in various public services, including healthcare. And what it tells you is what's happened over the last 25 years in terms of how much we are advocating, how much we are allocating to public spending versus private. If you go back to 1991, we as a country were spending more than 50% of our GDP on public expenditures, including health, social services, infrastructure, military spending, whatever. Over the last 25 years, that has progressively decreased, and we've gone from spending over 50% of our national resources on public expenditures to under 40%. Some of you may still think we're much more publicly spending than the United States, going back to what was happening 25 years ago. No longer true. In recent years, the public to private expenditures are very similar in Canada and the United States. So there's been this massive decrease in the proportion of our national wealth that we're ready to allocate to public expenditures, and that, of course, puts a squeeze on all public expenditures and potentially on healthcare as well. So, what is private and what is public? Physician and hospital services are overwhelmingly publicly funded, over 90%. Everything else is much more like the US-style mix of public and private. Prescription and over-the-counter drugs, over 60% privately funded. Home care for acute illness, rehabilitation, eye care, glasses, dental care, almost totally private. Physio and chiropractic mixed, and cosmetic totally private. So we have this system of quite separate, with respect to hospital and physician services, universal public access through public funding. And the question is that sustainable? And if it is sustainable, maybe we should extend it. So there are advocates for universal pharmacare of the same model as we have physicians. And then the question, my next question to you is, how do we decide whether it's sustainable? And here's the chance for any courageous individuals to speak up. How should we decide whether the Canadian healthcare universal system for physician and hospital services is sustainable? Anybody? No courageous people. I understand. All right. So I'm going to suggest a number of ways we might decide, and one is the proportion of our GDP that we're spending on healthcare. So when we think of our personal lifestyles, is our car, our vacations, our home sustainable? Well, it depends on our income. And higher income, much more is sustainable. So the key is, how much of our GDP are we spending on healthcare? And I have a question, and here I think I will get your participation, because all you have to do is raise your hand. I have a question for you about healthcare expenditure as a percentage of GDP in the last 6 years. Has it risen every year in the last 6 years? Has it risen most years? Has it decreased in most of the last 6 years, or has it decreased every year? How many think it's risen every year? Hands up. Okay, a lot of people think it's risen every year. How many think it's risen most years? Okay, now, maybe I think most of the rest. How many think it's decreased most years? Quite a few. Okay, good. How many think it's decreased every year? Anybody? Don't see anybody. Okay, that means you're all wrong. Okay? Because healthcare as a proportion of the GDP has decreased every year in the last 6 years. Okay? This is a pattern over the last 25 years. What you see here is the healthcare expenditures as a percentage of GDP. The flat portions does not mean that we weren't increasing our expenditures. What it means is that our expenditures on healthcare were increasing in proportion to the GDP. The places where it jumps up doesn't mean we're spending more on healthcare. It means that the GDP has stalled, and so as a percentage of the GDP with the same increases, which have averaged about 3% per year in real dollars on healthcare, then you have it go up. And then in the early 1990s, you have this extraordinary event. Canada is the only place in the world where this happened, where healthcare spending for a few years was flat, GDP was going up, so we actually had a decrease. But the most striking thing, perhaps for people, and nobody in this room was aware, although I'm impressed that quite a proportion was aware that most years had gone down, every year in the last 6 years, healthcare as a proportion of the GDP has decreased. And I'm going to end this talk by suggesting a mystery, but I'll introduce one mystery right now, which is, why did nobody know this? Why did most of you, I think the majority, thought it had gone up most or even every year? Why is this not information that we as healthcare workers know about. Why not? So, we can also think in terms of sustainability of healthcare on how are we doing relative to other countries. And we can ask, where did we stand as a proportion of our GDP back in 1992, and where does Canada stand today? Back in 1992, as a proportion of the GDP, we were the biggest spendthrifts aside from the United States. The United States has always been way out ahead as a proportion of the GDP spent on healthcare, but Canada was second with about 10% of our GDP spent on healthcare at that time. What has happened since 1992? What has happened is that we've done the belt tightening better than just about anybody else in the world. So that whereas we were second, we are now way down the list. So we are now spending about a little over 10.5, this data is a couple of years old, of our GDP on healthcare, but now most of Western Europe is spending more. We're no longer second, we're middle to the bottom third. US with over 17% of its GDP spent on healthcare is still way ahead, but we've held the line better than most countries, just about every country in the world, and so we've moved way down the list as a country in terms of spending of our GDP on healthcare. So, next thing is, where do we stand in terms of the proportion of our healthcare expenditures that are spent on, that come from public versus private funding? You'll have some people say Canada has a socialized healthcare system. Well, if what socialized means is public expenditures fund the system relative to private expenditures, relative to other countries. We're spending of every dollar that goes on healthcare, 70% comes from public funding. That is actually toward the bottom of the high-income countries. So you see a bunch of European countries, as well as New Zealand and Iceland, are over 80% public expenditures. Then you have a number between 75 and 80%, including France, which is pushing 80%, and Canada way down at 70%. So relative to other countries, we have much more or substantially greater proportion of private rather than public funding for our health care. I'm going to come back to France that you will notice now. I should have, see if I can go back. Doesn't work. So France was, as a percentage of GDP, it was 11.5%, a whole percentage ahead of us, and it is close to 80% of public funding. So, another anomaly in Canada. Canada's done a peculiar thing that nobody else has done with respect to the distribution of public and private funding. So we're spending 70% public, Germany and France over 75%. But on physician services, we're almost totally publicly funded, whereas Germany and France are lower. Same with curative and rehabilitative, that's largely hospital funding. Canada and France about the same, Germany less. But with respect to other healthcare issues, pharmaceutical, dental services, we have it almost all private funding or largely private funding, where it's much more balanced in Germany and France. So we've done this peculiar thing. Physician and hospital services, all or virtually all public funding. Other things, US-style two-tier healthcare, whereas other countries are more balanced across all healthcare expenditures. So, how does France do it? We heard about the older population, and we're all worried about our healthcare expenditures because everybody's getting, the distribution of the population is older. France has an older distribution of population than we do. They spend a larger proportion of their GDP, about 1% more, on healthcare than we do. And they have a larger proportion publicly funded. We're at 70%, they're pushing 80%. How do they do it? Higher taxes. That's how they do it. Okay, so that's how you, and I showed early on, we've gone from over 50% of our GDP spent on public services to under 40%. Has not happened to the same extent in other countries. So I'm now going to move, so I've given you some evidence that I believe bears on the sustainability of universal health care for physician and hospital services, not for other things so far, in Canada. I'm now going to move to how we decide public or private pay. So my question, I'm going to stop. I don't expect anybody to shout out, although I'll give you another opportunity to do so. But I'll give you at least 10 seconds to think about how would you decide what's best. We have Canada's 70% public, 30% private. Should it be more like the US with much more private? Should it be more like Norway and France, which much more public? How should we make the decision on this balance between public and private expenditures? How should we do it? Think about it for a few seconds. What criteria would you use for making this decision? Healthcare outcome. Okay, excellent. So public, thank you, Wes. Public or private, what yields better health outcomes? Okay, does it make a difference whether you spend privately or publicly on health outcomes? That's what we're all about after all. We're trying to improve health outcomes. Thank you. Okay, another 3 seconds to think about it. All right, here are I'm going to try to present some evidence that bear on these criteria. Autonomy, equity, cost control, quality of services, effectiveness, that's Wes's point of health outcomes, and cost effectiveness. What's the bang for the buck? So, how could we tell what's more effective? Ideally, we would have randomized trials. We would randomize constituencies, like randomize Canadian provinces, to more public or more private. As you might guess, there's a feasibility problem in conducting randomized trials of that sort. So therefore, I cannot, as a evidence-based medicine guy who would like to present information from randomized trials, sorry, can't do it. So we have to fall back on other sources of evidence that may be less compelling. So what are those other sources of evidence that might bear on the issue? One would be cross-national comparisons. I've already shown you some cross-national comparisons about the proportion of our GDP countries spend on healthcare and the proportion of the healthcare expenditures that are public and private. I'll give you some other comparisons as well. And then we can have some intranational comparisons. So I've already pointed out to you that physician and hospital services are publicly funded, whereas pharmaceutical services are over 60% privately funded. So that may give us some evidence when we look at what's happening for the services that are publicly funded versus the services that are mostly privately funded. And we have at least one, we have a couple of before-after comparisons. In other words, where things changed, where it went from more private to more public or more public to more private. That might give us some bear on all these issues that I've just listed about how we decide on the relative merits of public versus private funding. So, the first issue is autonomy. What do we mean by autonomy? Autonomy means that you can spend your money, if you have it, on one thing or another, and you can get what you want for your money. This is often presented as choice. In virtually every aspect of our society, we have a high level of autonomy. We can spend our money and we can buy a better house, a better car, a better vacation. We can pay for different education to an extent for our children, more so pre-university, university to some extent, but not as much as in other areas. But virtually every area we can pay for better. And that would be true within aspects of the healthcare system like eye care or pharmaceuticals, but it is not true for physician and hospital services. It's very difficult in Canada to pay for better physician services or quicker physician services or better or quicker hospital services. This compromises autonomy. Universal health care undermines or compromises autonomy in terms of being able to pay for better. So if autonomy is something you value well, and indeed when I go to the United States, people can find it hard to believe that you cannot pay for better hospital and physician services or quicker within Canada, or only to a very small extent. And some of them are very horrified at the idea of the compromise in autonomy that universal health care represents. So if autonomy is highly valued, private funding of health care is the winner. What about equity? Well, intuitively no surprise that if you have universal health care without financial barriers to care, equity is going to improve. Here's a bit of evidence that substantiates this thing that I think we would know quite intuitively. This has to do with avoiding or foregoing health care, whether you have an income below the average for Canadians or above average. And you can see that when you have to pay for your prescriptions, 22% of Canadians in this particular survey said that they did not fill drug prescriptions because it cost too much. For those above average income, considerably less. Even more extreme with respect to dental care. And I've heard it said that if you have an elderly patient and you want to guess of what their income was throughout their lives, go into their room and have a look at their teeth. The dental care, 42% in this did not get dental care, for which you have to pay almost completely privately. If you were below the average income, considerably less above the average. Whereas on health care for physician and hospital services, where it is publicly funded, the gradient was much less. And those below average income may have already been thinking, I won't bother to go to the doctor because I won't be able to fill the prescription that the doctor is liable to provide. So bottom line here, when you have more private funding, you have a bigger gradient and equity problem. To the extent we value equity, you have an much greater equity problem with private funding, where people have to pay out of pocket, much less within publicly funding. Next issue, costs. Okay, here's another question for you, and here all you have to do is raise your hands again. Let's say tomorrow we allowed private payment for quicker, better physician and hospital care. I pointed out that's the one area of our system that's largely universal, almost totally publicly payment. Can't pay for better or quicker care. Let's say we change that tomorrow and we allowed Canadians to pay for quicker and better physician and hospital care. What would it be? What would the effect on healthcare expenditures be? Would they go, total healthcare expenditures, would they go down? Would they stay the same? Or would they go up? Who thinks they would go down? Anybody think they would go down? Who thinks they would stay the same? You people. Who thinks they would go up? Okay, this time you are right, okay? And there is pretty good evidence, I would say, to support that. And the evidence is a cross-national comparison. So up until this figure starts in about 1970, but if I went back right to 1910, the US and Canada would be in very much in the same place as healthcare spending as a proportion of GDP. But something happened in around 1970 that changed it. Since 1970, a huge divergence, getting bigger all the time in the proportion of GDP spent on healthcare, where US is now over 17%, and we are still hanging around. I pointed out, gone down the last 6 years. We're still hanging around. Again, this is a little old and slightly different figures from different places, but hanging around between 10 and 11%. So something happened in 1970, didn't it, right? Before that, for the 50 years before, we were the same, and something happened in 1970. People who are older in this audience might have been around to see what happened in 1970. What happened in 1970 was national Medicare in Canada. That's when we started to pay publicly for physician and hospital services. And this is evidence to support what almost all of you said, that we switch to a US-style mixed system with respect to physician and hospital services, the consequences in terms of our healthcare spending would be pretty clear. How come they spend so much more? Well, sadly perhaps, part of it is not that they spend so much more, they do, on actual delivery of health care, but they spend, the biggest gradient is in healthcare administration. We're spending about 16% of our healthcare expenditures on healthcare administration. They're spending over 30% of their healthcare expenditures are on administration. Why? Well, as soon as you start asking people to pay for their health care, because health care is the sort of thing like what might happen if your house burns down or what happens if you get in a car crash, basically your expenditures are low until you hit some kind of disaster, and then the expenditures go way up. Under those circumstances, that's when people buy insurance. So when people in the United States have to pay for their health care, they have to buy insurance or go uninsured, which of course Barack Obama tried to deal with, and it looks like Donald Trump is going to scale back those efforts to minimize the people who are uninsured. But at any rate, if you have the money, you will pay for insurance. So that means you go to insurance companies. And what are the obligations or necessities for those insurance companies? They have to develop the insurance packages. They have to compete with one another to sell the insurance. They have to evaluate the applications when somebody says something has happened, please give me back the money. They have to document the use of services in both physicians' office and hospitals. In big American hospitals, they have a big adjacent building that takes care of all the billing. Canadian hospitals have a little office with 2 or 3 people and a couple of laptops. They have to assess the claims when somebody makes a claim. The executive salaries within our publicly funded, publicly administered system do not compare with the CEO and top executive salaries paid to U.S. insurance company. And of course, they have to make a profit. None of these publicly funded, publicly administered, zero. None of these are totally trivial. So the result is, here's I look at the last column, number of employees per 10,000 enrollees. Here's American companies. The best is Mid-Atlantic Medical Services, and the best that spending has 14 employees per 10,000 enrollees. The worst is United Healthcare with 35 employees per 10,000 enrollees. What about the Saskatchewan and Ontario health plans? 1.4 and 1.2, okay? Private insurance, huge administrative costs relative to publicly funded, publicly administered insurance. Okay, cost control. Now I'm going to do an intranational comparison. This intranational comparison compares the universal publicly funded physician and hospital services to the mixed funding, majority private funding, pharmaceuticals. So over the last years, physician and hospital spending, physician spending has been largely the same, around 15%. We've actually had a massive decrease in the proportion of our healthcare expenditures that go to hospitals. We've moved hugely expenditures out of hospitals, and we've gone from 45 to 30%. Public funding allows control in a way that private funding does not. And pharmaceuticals, largely privately funded, have jumped, and now we're spending considerably more of our healthcare dollars on pharmaceuticals than we were in the past. Okay, another criteria, move to another criteria for how to judge which is preferable, public or private funding, and that is waiting lists. Well, what's the logic? Why might private funding improve waiting lists? Well, you get more money. We've already established we're going to spend more money in healthcare if we go to private funding. Brings in more money, more resources, and wait times might get shorter. Is there logical reason to think that that argument would hold up? Well, perhaps not. What are the constraints that lead to waiting lists? Physician and nursing shortages are part of it. Private funding will not train any more physicians and nurses, and it may be that publicly funded facilities would lose the best trained individuals. Perhaps even more compelling, why would somebody spend on private health care when you can spend on public expenditure? Well, only if there's problems in publicly funded facilities. And what are the big problems people are worried about? Waiting lists. No waiting lists in public funding. Who's going to spend on the private? Finally, if we're all in the same boat, the affluent, those with the money, may be much more inclined to support public expenditure than if they can opt out for their own health care. Well, now we have another, so those are the logical arguments, but what about evidence? Here we have another before-after comparison, and that is Australia. Over the last 20 years, Australia has had a big move toward two-tier health care. 20 years ago, they were largely in the same place as Canada is now with respect to physician and hospital services, very largely publicly funded. They've moved away from that. Now, the government in Australia gives people subsidies to buy private insurance, and most recently, they penalize the wealthy who don't buy private insurance. So, big move in that direction. Well, what is the relationship? What's happened in Australia with respect to waiting lists? This was a study done a while ago. On the left side of this figure it says more private care. So within Australia, this was an intranational comparison within Australia, and after the big move toward private funding, and it looked at areas where there was more private care and areas that was more public care. That is on the x-axis. On the y-axis is mean waiting times. And what you can see here is the more private care, the longer the wait times. Now, what is the direction of the causation? Is it that private care causes the wait times, or is it that where you have wait times, it encourages the proliferation of private care because people feel they have to buy their ways to the front of the line? In the areas of more public funding, lower wait times. And the rather conservative conclusion that Professor Duckett came to was policymakers should be cautious about assuming that additional support for the private sector will take pressure off the public sector and reduce waiting times for public patients. Colleagues of ours, economists at McMaster University, have done a study of this move from public to private in Australia and came to the following conclusions. Australia's experience provides a number of lessons. The potential for cost savings through introduction of expansion of a parallel private sector is very limited, and in fact, that's a very conservative conclusion. What the United States showed us and what almost everybody in this room intuitively knew is costs will go up. The introduction or expansion of a parallel private system is unlikely to reduce wait times, and that Dr. Duckett's evidence that I have shown you bears on that. No simple way to regulate private insurers, and impossible to not have one system influence the other. So, now we get to Wes's point. What about health? What about health outcomes? So, as it turns out, the big outlier, as you have seen, in terms of more private funding is the United States. So let's compare the United States and Canada. We have appreciably lower infant mortality, and we have longer life expectancy. One may say, however, this may have little to do with health care. Americans, for example, have a much greater habit of killing one another with firearms than do Canadians. So that is one reason, and that presumably has little to do with health care. So what can you do? you can complement this by looking at conditions that people think are amenable to healthcare interventions. So this was a study, and you will look at the rank. What I'd like to point out, France is number 1 in terms of reducing mortality for conditions thought to be amenable to healthcare. Canada, not too bad at 6. Look at the United States, bottom of the list. The country that has most private funding is the one doing worst on preventing deaths amenable to health care. We looked at this a few years ago ourselves. We did a systematic review of all the studies that compared outcomes in Canada and the United States for patients with identical diagnoses: cancer, cardiovascular disease, dialysis, and cataracts. 14 studies showed better outcomes in Canada. The better studies, those with broad populations and statistical adjustment, 5 out of 10. 5 studies favored the US, 2 out of 10 high quality, 19 were equivalent. When we first submitted this paper, we were conservative in our conclusions. We say health outcomes seem to be about the same. The reviewers said, no, come on, this clearly favors Canada. So we were happy to change our conclusion in accordance with the reviewers. So, efficiency. Health outcomes conservatively are the same in public and private systems, or systems that are more public versus more private. A less conservative would say, if anything, the public systems, perhaps because of better equity, end up with better health outcomes. The costs, no argument. The publicly funded systems are considerably lower cost than privately funded healthcare. So if you're talking about efficiency, the bang for the buck, the same or better outcomes at lower costs. So let's look at the scorecard. Autonomy, private funding wins, okay? When you can't pay for better or quicker health care, that is a violation of your choice and autonomy. So autonomy, private funding is a clear winner. Equity, I think no problem. Cost control, you intuitively all had the right idea, and the evidence supports your intuition that cost control is easier in the public. Waiting lists, a conservative interpretation of the evidence, would be little or variable impact. If anything, the evidence suggests maybe waiting lists shorter with public funding, except, of course, for those who can pay for the private. But if you're looking overall at the population, little or variable impact, or in fact longer waiting lists. Health outcomes, again, a conservative interpretation would be similar. A less conservative interpretation of the data would be better health outcomes in the public. Again, it kind of makes sense in terms of the equity argument. If people can access health care to the extent that health care improves outcomes, you're going to get better outcomes. Efficiency, it seems very clear. In terms of bang for the buck, health outcomes per dollar spent, public funding is superior. Now, I said I was going to end with a mystery, and here is the mystery. The mystery is, with this balance sheet, why is there any debate? Why don't we all say, let's have universal pharmacare now so that we can gain the equity and efficiency advantages that we have for physician and hospital services? Why are there still people pushing in the other direction and trying to get us to move toward private funding with this balance sheet? Taxes, okay, right. Okay, good. Okay, so we saw earlier, we've gone from in the last 25 years, we've gone from 50% of our national wealth spent publicly to 40%. People like to reduce taxes. So even if we would gain efficiency, better health, possibly better health, certainly overall spending less, we're not only worried about overall how much we're spending. We're worried about how we're spending it. We may say, okay, I'm ready to spend more as long as it doesn't go in my taxes. Perhaps. So that's good, okay? Any other suggestions about why there is still a debate with this balance sheet? Okay. I'm glad you're getting into it now. That's good. Okay, yes, over here, somebody.
Selfishness.
Sorry, say again?
Selfish.
Selfish, okay, yes, selfish. But selfish for who? I thought we just said people are better off, overall, they're better off with public expenditures. Who is selfish here? Yes? Insurance companies, okay. Yeah, but insurance companies don't have much play in Canada. They certainly stop moves toward public funding in the U.S. Insurance companies are a big force in stopping movement toward public funding in the U.S., but they don't have much play in Canada. We've kept them out by having public funding so far. I hear other thoughts?
Big pharma lobbying.
Big pharma lobbying, okay, so that is a good reason why we're not moving toward pharmacare, maybe that lobbying. Okay, yes? Poor government, okay, so poor government. So the government is doing a bad job of giving with health care. What do most physicians complain about? How are they doing a bad job? They're not giving us enough money. I think that's where most of the complaints would be. How can you remedy that? Get Canadians to pay more taxes. Then you have more money for public services like health care. All right. Okay, great suggestions. Here are another set of suggestions that you might want to consider. Maybe Canadians place a very high value in autonomy. That's not what Roy Romano, a decade or more ago, when he did his surveys of Canadians' views, Canadians valued equity highly. But maybe things have moved, because that's the one area where private care is the winner, autonomy. Maybe we're really only concerned, who cares about overall costs? Somebody said, low taxes, let's just keep the taxes down. We're only really interested in public sector costs. If we pay more overall, who cares, as long as we keep public costs down. Or the balance sheet that I gave you within evidence-based medicine, we talk about subgroup analyses. Subgroup analyses are some people, a treatment works, but not for everybody, or a treatment doesn't work, but some people benefit. There's a subgroup analysis here. The balance sheet that I gave you was for average Canadians. It may be different for the wealthy. If the wealthy can always pay their way to the front of the line, then if you don't care about anybody else, it's a different balance sheet. And perhaps, going back to the question, why did so few people, I was pleased at how many knew that more or less it's gone down. Nobody knew that health care as a proportion of the GDP had gone down every year in the last 6 years. Why not? Who controls the information that Canadians receive about such matters? And for us, healthcare providers, for those of us who put a high value on equity, well, it's still the public funding is the winner. For those of us who put a higher value on our incomes, well, maybe a different story. Thanks very much for listening. Thanks very much for your engagement, particularly toward the end. It's been a pleasure to talk to you.